I'm Sajjad Fazli. I'm discussing with you a few tips in phacoemulsification myopes. We know that cataract surgery is arguably most powerful refractive surgery because the new lens implant can correct just about any degree of myopia, astigmatism, and even presbyopia at the time of surgery. Highly myopic patients with preoperative refractions of -10 or more are often the happiest because a lifetime of nearsightedness is finally cured with the successful surgery. However, these myopic eyes pose challenges and additional risks during the surgery and in the perioperative period. We know that these eyes have low scleral rigidity. So these low scleral rigidity means that there is going to be an anterior chamber collapse when removing the phaco or the IA probe from the eye. So every time that happens, the posterior capsule and the vitreous tend to move anteriorly, and once that happens, and there's a traction or tension on the vitreous base, and that might lead to a PVD. And once there's a PVD, there can be many sequelae of the PVD intraoperatively and later on. One is a retinal development of a retinal break, and that retinal break might proceed to a retinal detachment, it might not, or it might lead to a vitreous hemorrhage, and that it can lead to a retinal hemorrhage or a cystoid macular edema. So we're talking here about all possibilities of all these complications of cataract surgery in myopia being related to the anterior chamber collapse because of lower scleral rigidity. So I'm going to point out certain ways by which we can avoid the collapse of the anterior chamber in myopes intraoperatively. You can see what has happened here is one important thing which you have to look at. That is that in myopes, because the anterior chamber depth is bigger, there's an advantage in the cataract surgery in these patients, which allows more working room during the phacoemulsification. However, the infusion pressure from the phaco handpiece can cause overinflation of the anterior chamber and tendency to push the anterior lens iris diaphragm back. You can see before I take out the phaco probe, I'm injecting viscoelastic from the side port. Now, then you are coming out. That what that allows is that the anterior chamber fluctuation does not happen, and you proceed without having much changes in the anterior chamber depth. Again, before I'm taking out the IA probe, you can see I am inflating the chamber again and then coming out. Sometimes there is a difficulty uh, injecting the viscoelastic because before you can actually stop the irrigation and then inflate, it becomes much easier. And all these patients, you will see that at all 3 points where the chamber fluctuation can occur is when you're taking out the phaco and the tip after doing phacoemulsification, when you're finishing and doing an IA and taking out an IA probe, and at the end when you are removing the viscoelastic. Here you can see what I've done is that I've seen some stromal hydration, then leave it in the incision so that it causes some amount of stromal hydration, and that has helped me in reducing the fluctuation in the anterior chamber depth or the time at which the different times at which it might have occurred, making the surgery a little bit more safe. So these are all maneuvers to avoid the collapse of the anterior chamber. Here you can see again another case where I'm this time removing the epinucleus. You also have to understand a big bag means sometimes the capsule might not be that taut. It can be a little floppy. Before I come out, again I'm putting some viscoelastic through the side port and then coming out with the same idea, reducing the fluctuation. Again, demonstrating to you finishing of the IA. It's also important to remember that another most important thing in myopes is that you should be doing a neat, clean cortical cleanup, because if you leave cells there, the need for YAG capsulotomy is early, and you can see again before the eye probe is taken out after a good, clean, thorough cortical cleanup, I'm just injecting viscoelastic again. So that has, and then putting some more through the main port. You can see a minus 5 IOL has been implanted, and very easily, because now the size of the rexus is good. And you can see I'm stromal hydrating a little bit before the IA probe goes inside to remove the viscoelastic. That gives us an additional edge of controlling the fluctuation in the anterior chamber. Then while you're coming out, leave it there. Now complete your stromal hydration nicely. It is never good for a myopic eye to be in a hypotonous state. Now you're seeing that the eye is absolutely taut and things have been done nicely. So another thing which we are confronting nowadays is those people who had a radial keratotomy done when it was quite popular are now developing cataracts. Here you can see I've chosen not a corneal incision, not a limbal incision, but a scleral incision. So obviously the scleral incision is much safer in these cases. The side port incision has to be in between the corneal incisions which have been created, the keratotomies which have been created. Again, you can see here the cataract surgery will progress almost as the same as any other myope or a high myope. So you have to take the same amount of precautions, and those precautions which I have already demonstrated to you vis-a-vis chamber fluctuation. You can see I'm going in and injecting some amount of viscoelastic and then coming out with the IA probe infusion off, going in and cleaning up everything. The cortical cleanup, again, I told you, is very critical. You don't want the capsule to be opacifying very quickly, so that you need a YAG laser. And once that is done, before you take out the IA probe, you go in again and inject. So these people might not have very thick glasses. You have to keep your mind that the corneal correction does not make the behavior of the eye any different. It's going to behave during the surgery the same way like any other myopic eye would do. The only thing in patients who have radial keratotomy done is that you will always have to have a look at the end of the surgery at these keratotomies and see whether they're leaking. Sometimes they even have to be sutured. But there's an edge and advantage of using a scleral incision in this, because these incisions at least do not. So a repeated dilated fundus examination is indicated to search for any possible retinal breaks or weaknesses that may have been created during the surgery. For that, it's very important to remember that the rexus size has to be good enough to ensure peripheral retinal visualization post-op. Same precautions. You can see the rexus size is small, slightly smallish. You've been able to do a phaco, and before you take out the probe, you inject some viscoelastic. Then you do an IA, and at the end of the IA, before you remove the IA probe, you do a viscoelastic. You put in a viscoelastic and inflate the chamber. So after you do that, you can see here there's a 3-piece lens which I'm going to implant. So though the rexus size being small might actually give a little difficulty implanting the lens, because 3-piece lenses are slightly more bulkier and more difficult to put in through smaller rexes. But again, there can always be a struggle through a small rexus. So the small rexus is not just an issue of whether you are able to do a safe phacoemulsification or not. It's also a matter of with what ease you can implant. You can see here, finally it's implanted, but I'm not really happy with the capsular rexus size, because a small amount of phimosis might lead to our peripheral retina visualization being very, very difficult. So it's always good to go in again and resize your rexus so that you have a good sized rexus. So surgery doesn't actually just mean finishing off a case nicely. It also means that you're looking all the factors which are going to be there, or which we expect are going to give us difficulty in the immediate post-operative period or delayed post-operative time. You can see here again I've done some amount of stromal hydration before the viscoelastic is removed, with the same idea that in a floppy, in a less rigidity sclera than anterior chamber, fluctuation is going to be more, can become hypertonous. And at the end of the surgery, after removing the IA probe, again I'm going in and doing the stromal hydration. Thank you all for your kind attention.